Good afternoon, everyone, and welcome to the At Research webinar for today. It is a pleasure to have so many of you join us from all around Australia. And of course, it is a great pleasure to be once again sharing some of the amazing health services research that's happening in regional Australia. My name's Heather Cameron, and I'm the Program Manager for the Revitalise Project's Regional Research Teaching Hub, and we, of course, are the hosts of At Research website. So on behalf of the Regional Research Teaching Hub and all of us here today, I would like to begin by acknowledging the traditional owners of country throughout Australia. I recognise their continuing connections to lands, waters and communities, and I pay our respects to Aboriginal and Torres Strait Islander cultures and to elders past and present. And I do extend a very warm welcome to Aboriginal and Torres Strait Islander people who are joining us today or perhaps viewing the webinar recording. So just some housekeeping before we start. There will be an opportunity to ask questions to our presenter, so please use the Q&A button at the bottom of your screen. There will, of course, be an evaluation circulated post-webinar, but it'll also be available through a QR code at the end of the webinar. So I encourage you to provide feedback to the presenter and to our team as it helps with planning future webinars. And of course, there will be access provided to the recording of this webinar via the At Research website. So welcome. And without further ado, I'm now going to hand over to Associate Professor Craig Underhill, one of the co-leads of our team, and Craig's going to facilitate our webinar today.
Hello everyone, welcome. Thank you for joining in the webinar. I'd also like to pay my respects to the elders, First Nations custodians of the lands and waterways. I'm talking to you from near Albury-Wodonga. You can see the Murray River in the background, the bottom end of Wiradjuri country, and the Victorian High Plains behind, which is Jaimathong country. So I'll just firstly introduce Stacey Rich. Stacey is a health services researcher with a focus on supportive care for people with cancer. Her undergraduate degree and subsequent PhD in psychology science provided her with a deep curiosity for research methods. She's the project manager for the Tropical Vic project, which we're talking about today, which is timely referral to outpatient palliative care services in regional Victoria. Like most regionally based researchers, she has a track record that on the surface resembles Aldi's Middle Aisle. Stacey wrote this, not Monty Python. So I'm thinking you mean pick what you like out of the middle aisle at Aldi. She's researched everything from eudaimonic well-being in low consumption lifestyles to fear of cancer recurrence, geriatric oncology, family services and care workforce. As a result, she has dabbled in a wide variety of research methods, all without leaving regional Victoria. Stacey's experience of caring for her mother through advanced pancreatic cancer to the end of her life gives her an inside perspective on what happens when families do not access palliative care until it's too late. So thank you very much, Stacey.
Beautiful. Okay, I will share my screen. Just bear with me while I do all of the clicking. Okay. So as already mentioned, are we making it up as we go along? Let's get started.
I feel like every time I get a new box, I feel like it's Christmas. Except the stuff I'm unboxing is failure. Hi, I'm Samuel West, and I'm the curator of the Museum of Failure here in Helsingborg, Sweden. It's a collection of failed innovations that we can learn from.
Okay, So as researchers and health service providers, we want to make sure that the innovations that we're implementing will stick. So depending on the scope of change, the organisational context and the criteria that we're using to define failure, anywhere from 30 to 90% of health innovation implementation fails. So as a project manager for an implementation research study, I am very interested in keeping our project out of the museum of failure. So now that I've primed you all with thoughts of failure, let me introduce myself. So I'm Dr. Stacey Rich and I'm Project Manager of Tropical Vic. As already mentioned, Tropical Vic stands for Implementation of Timely Referral to Outpatient Palliative Care Services in Regional Victoria, which is quite the mouthful. So I would like to acknowledge the traditional owners of the unceded land that I'm coming to you from today. That's the Doodaroa and Waywuru people. So believe it or not, I am the little blondie on the left of this photo. To my right is my older sister, and that's our mum, Paula, at the back. So this time last year, mum was in the last 2 weeks of her life. She was intubated, she was eating and needing to be aspirated almost immediately after eating. She was chewing on Panadol still and refusing morphine. She was also attempting to convince her oncologist that the pain she was experiencing in her stomach might have been something that she twisted when pulling out the hose reel. So mum survived almost 15 months after emergency surgery to remove her colon. At that point, we discovered that she had incurable pancreatic cancer. We didn't know that beforehand. So during that time, we spent countless hours in waiting rooms. We were in EDs, we were in chemo, we were driving between services. She did not want to make decisions about her end-of-life care, and she was not ready to die. She was exhausted, and so were we. So that makes me a lived experience researcher. So when the opportunity to get on board with this project came up, it made absolute sense to me to get involved. But that's enough about me and my backstory. Let's talk about Tropical Vic. So what is Tropical Vic? It's the result of a successful grant application to what was then the Victorian Cancer Agency under their Palliative Care Cancer Research Scheme. So this 3-year project proposed 3 objectives. First one was to use a collaborative consumer-driven approach to co-design so that we could co-design a system of screening for palliative care needs for people with advanced and incurable cancers in order to make sure that they could access the benefits of early referral to palliative care. Second objective proposed was implementing an outpatient early palliative care delivery based on needs identified by that screening, and that involved setting up an outpatient clinic. And the third was to measure the impact of outpatient early palliative care in our region. So all of this is no small feat given that early referral is not common practice in our region and we currently don't have an outpatient palliative care clinic. So we are starting from scratch. So Tropical Vic has a fantastic steering committee that's made up of a group of really motivated people that include cancer care clinicians, consumer representatives, some researchers, health service managers, and myself. So I will use the term we throughout this presentation because it really is a group effort, although sometimes obviously it's the royal we and we is me. But our steering committee I wanted to highlight because they developed this wonderful mission statement. And I believe that this is where the engagement really started in this project. So each person on the committee had some input into this statement, and this is what guides what we do. So I will read you the statement verbatim. I don't like to read off slides verbatim, but I will this time. So Tropical Vic supports people with advanced cancer to access palliative care in a timely manner. By co-designing and implementing a model of early referral to palliative care, we will provide access to holistic care that prioritises the needs of patients and their families, fosters dignity and improves quality of life. So that's what our project is all about. So we should probably start with what we mean by palliative care. So I won't read this definition out. I'll leave it to you guys to read it to yourselves. But palliative care is one of those terms that's had to evolve to really outrun the negative connotations that it has. So the term was first used in 1974 by an oncologist, a Dr. Balfour Mount. So as the story goes, Dr. Mount coined this term to avoid the association that hospice care had with death. So he came up with this term palliative to mean more supportive care. So unfortunately, the stigma of death and dying is kind of stuck with that name. And the common misconception about palliative care is that it's all about being the end of the line and the giving up of hope, which is definitely how my mother saw palliative care, I think. But as you can see from this WHO definition, palliative care is just so much more than that. So why early referral? So we've got a lot of evidence demonstrating the effectiveness of early referral to palliative care for patients with cancer. So we've seen improved quality of life, improved mood, and improved survival outcomes. We also see a reduction in emergency presentations and hospital admissions in the last month of life. There's an increased likelihood of death at home, which is quite often the preferred option, and savings of up to 25% of total healthcare expenditure when you compare it to care as usual. So patients and their families also report satisfaction with care when palliative care is added to their usual care. So it's a good idea all round. There's a lot of new models of early referral to palliative care that are being developed all around the world, but often they're developed in metropolitan health services that have great resourcing and that have research capability, firmly embedded in them. So the question we need to consider for our project is how can we make these models work effectively in a regional context? So first we have to recognise that while metropolitan models provide valuable insights, they often need adjustment to fit the unique characteristics of the regional communities that they're being implemented in. We also can't forget the importance of community involvement. So engaging local stakeholders will ensure that models reflect the specific needs of the population that it's going to serve. And we also can't ignore the fact that resources that are available in urban settings might not exist in regional areas. And if they do, they might not be readily accessible. So these are all issues that we needed to consider to ensure that this project has every chance of success. It's also worth noting that our particular regionality has added layers of difficulty. So this is the catchment area that this project's operating within. So some of you on the call might recognise the building in this photo. This is the Albury-Wodonga Regional Cancer Centre. And this is where our referrers work, and our participants will probably receive their cancer diagnoses and their chemotherapy, their radiotherapy, and all the care and attention of the really wonderful staff that are contained within this building. And as you can see from the map, so Albury-Wodonga Regional Cancer Centre is here in Albury. It's attached to Albury-Wodonga Health, which is a Victorian health service that is based in New South Wales. Also extends into the Wodonga LGA here. So you can also see that the Murray River cuts right through all of this catchment. So we've got a Victorian border, a Victorian New South Wales border, and then we have 6 local government areas. So we have borders between those local government areas as well. So just to give you an example of the complexity that this brings, I'll use mum as an example again. So my mum and dad lived in Federation Shire for most of their lives, or at least 50 years, which is up here. And when mum came out of hospital from emergency surgery, which happened down here in Wangaratta, she came to live with my family up here in Towong Shire. Hopefully that pointer is actually working so you can see where I'm pointing to. So you can see we were spread across quite a few local government areas and also across borders. So because our address was in Federation Shire in New South Wales, we were referred originally to a New South Wales palliative care service. Once they contacted myself and I let them know where mum was staying in a Victorian LGA, we were advised that we'd need to speak to Wodonga Palliative Care, which is on the Victorian side of the border, and Wodonga is its own LGA. So once we were in contact with Wodonga Palliative Care, they then referred us out to Towong Shire, to the community nurses, community and district nurses out there. So for somebody who already was working in cancer research and knew quite a bit about services already, I found that quite difficult. So I can't imagine what it would be like for somebody who's never had any contact with this kind of complexity. So given all of that, given all of these borders, given all of these different fractured services, how do we ensure that the early referral model that we're developing is appropriate for our situation? So the answer for the grant writing team, the investigators that managed to secure this grant, the answer to that was obvious. It was co-design. So when models of care are developed in metropolitan health services, they're often designed around the resources, staffing, and the patient needs that look very different to what we have out in regional areas. So simply taking a model and plonking it into a regional setting rarely works. So co-design is really valuable because it brings local voices into the process, adapting those models. So you can include patients, clinicians, community members, anyone that will be coming into contact with these services can be included in the design. So it also allows us to understand the unique challenges and strengths of regional services and to tailor the care approaches so that they're realistic and sustainable, and also so that they meet the actual community need. Rather than just making assumptions, co-design ensures that change is built with the people it affects. So this leads ultimately to better engagement, I think, and a lot of people think this, better outcomes and ultimately better health services. So given that co-design is such a valuable method of designing anything, it's a bit of a lay down misère, but at the same time, it's time consuming and it's very resource intensive, especially when you're starting from scratch. So like a lot of people listening in today, we were working within a really strict time and funding limits. So we had to adapt by splitting this process into two parts, as you can see from this diagram, complicated diagram on the left. So we began with a scoping review to build a strong evidence base for what we were looking for and identifying existing models of care and also best practices. So this meant we weren't starting with a blank slate and we had a framework that we could build our co-design workshops on. So from this foundation, we were able to work with our co-design team to modify and adapt the evidence-based components of other models so that they would suit our context. So this approach freed us up to focus on the co-design efforts where they were needed the most in ensuring that that model was locally relevant. So while we were still delivering the work within 3 months, we had this roughly 3 months to get this done. So we managed. We believe that this was a practical, efficient way to balance meaningful engagement with real-world project constraints. So beginning with the scoping review, the scoping reviews are a really great way to map out the existing literature on the topic. So it helps us to understand what's already out there, what approaches have been tried, and where there might be gaps. So we chose this method because we needed to answer some key questions fairly early on. How is early referral to palliative care currently being done? What models already exist? And importantly for us, is there anything specific about how early referral is happening in rural and regional areas? So the scoping review gave us a clear overview of the field, helped us to identify relevant models that we could learn from, and meant that we weren't reinventing the wheel. We just didn't have time to start from scratch. So it gave our project a really strong evidence base to build on before we moved into that co-design phase. So one of the first things we discovered in this process was that somebody had very kindly and very recently already completed a review of models of early referral to palliative care. So that was really very helpful. And as suspected, within that review, there weren't many models developed within regional or rural health services. So there was still that piece missing for us. So we concentrated on reviewing models of delivery of palliative care in general in regional and rural areas. A lot of different areas have come up with some pretty unique models based on their geography, based on the people within that area. And there's a lot to learn from how palliative care can be delivered. So the review work highlighted quite a nice structure for us to work under for the model development. And that included these 5 stages of early referral. They're really quite neat stages. So identification of who might benefit from early referral, how you might screen people for palliative care needs, how you go about discussing palliative care with patients, the actual referral nuts and bolts itself, and then the provision of care. So the scoping review gave us those building blocks that we needed to get started, and it was a bit like putting together Lego pieces. So we pulled the key information from the review into a pre-reading document, and this gave everyone a shared foundation before the workshops. So we then planned 3 online workshops to bring people together to build on that base. So to support this, we developed a flyer, identified some key stakeholders and sent out invitations, and we were all ready to go. The idea was to make sure that when people came to the workshops, they weren't starting from scratch. They already had a sense of what was out there, and we could focus on adapting and improving rather than brainstorming. When the workshops were designed, we really had to think about how our regional setting and our target audience's lives would impact this process. So we were working with some very busy people who weren't necessarily in the same localities. Meeting face-to-face is ideal for co-design, and it really does serve to bring people together really well, but the practicalities of getting everyone in the same place at the same time meant that we had to adapt again. Lots of use of the word adapt throughout this presentation. So we plan to run online workshops using Microsoft Teams. So each workshop was structured around those 5 key steps that we'd identified during the scoping review. So the activities we were really able to target and focus in on each step. So on the left-hand side here is the Microsoft whiteboard environment that we used in workshop 1. We used Microsoft Whiteboard to keep everyone engaged and working together. So this meant that the participants could brainstorm, add ideas, collaborate in real time, move things around, speak to each other, chat in the chat function in Teams. And though I don't receive any sponsorship from Microsoft, it just so happens that these things all work really nicely together. So the goal here was to create a space where everyone's voice could be heard and where we could build on the evidence in a way that made sense for our regional context, even though we weren't in the same room. Of course, things didn't go quite the way we expected. So originally we'd planned for 3 full workshops, but as you can see, that plan had to change. We ended up crossing out the original plan and shifting to 2 workshops, broken up over multiple shorter sessions just to get enough people in the virtual room. So we had to change the times more than once, trying to fit around people's availability, which got even harder. And I did start to panic because we were heading towards Christmas, and anyone that works in a health service will know that everybody takes leave over Christmas, extended leave. So at the same time, we were also under a lot of pressure to meet the funding milestones. It felt a bit like building with Lego blocks while the table was moving and someone was taking away my bricks. So we were constantly adapting as we went through this process, but by staying flexible, we managed to keep the project on track and to get the input we needed. Okay. So workshop 1. So we ended up running 3 smaller group sessions instead of 1 big session. We had a total of 14 participants across all of these sessions. We had a really rich mix of people involved, from consumer representatives, palliative care, cancer care, health service research, oncology, cancer care coordination, public health, health service leadership. So we had a really nice mix. Everyone brought a different perspective to these discussions. Each group worked through the same set of activities, and the insights they shared helped us start shaping an initial draft of the model. That early work then fed directly into workshop 2, where we refined and adapted the model even further based on more feedback. And we also saw 4 major themes arise from these original discussions, and these appeared to be top of mind for just about everyone that engaged in these workshops. And that was more about thinking how early referral to palliative care should be delivered, what the important aspects were aside from the model itself. And that sort of centered around education, discussion, removing barriers to referral, and the referral triggers themselves. So I won't go through those themes because it's kind of not what I'm wanting to get across in today's presentation. Okay, so moving on to workshop 2. Workshop 2, we presented participants with 2 draft models that have been developed based on the work from the first workshop. So this is these 2 models up the top here. The two versions were very similar, but there were subtle differences in who was delivering what parts of the model. So after some discussion, the group chose the second model as they felt that that worked best for the context that we're in. From there, we used a modified journey mapping activity to really dig into the model and identify potential pain points down here and potential opportunities. So again, those 5 different phases of early referral, and then we had an opportunity to put thoughts and to further refine things through the whiteboard. So this process helped us refine the model even further and make sure it was as practical and as workable as possible for our regional services. So after that co-design period, we had a solid model for early referral that the team had developed together, which you can see here on the left. The next step was turning that model into something that could actually be implemented on the ground. So we had an ideal state that we thought would work, but implementation on the ground is another thing altogether. So to do that, we set up a working group, and this was made up of key health service staff who will be directly involved in the clinic in some capacity. So the role of this working group is now to take this co-design model and figure out the practical side of things. What needs to happen to operationalise the clinic and make it work within our existing systems. So these are the people that are working in those systems and can really understand what will work and what won't. They're currently going through further discussions and refinements to continue to shape that model so that we can be really ready for clinic implementation later this year. Now for what I think is the most important part of today's presentation. So this is the lessons that I personally have learned during this process. So prior to this, I had very little to do with co-design. This is my first time working in co-design, so I had to learn a lot along the way. I tapped into some really valuable resources in people that I've worked with previously, and obviously read all the books that everybody else reads on co-design. But as far as lessons learned, the biggest one is to never underestimate just how busy people are. This will really throw a spanner in the works, or as in this photo, a rock under a skateboard. Another thing is that you really need to sit in the murkiness of not knowing where things are heading. So for a lot of researchers, especially if you're a quantitative researcher, which is my background, you're more comfortable following in the footsteps of other people and knowing where you're heading. And with co-design and working with people and working with services and big systems, you will never know where you're going to end up, which is challenging but also exciting. And you also have to know when to give up and change tack. So you can have all of the best methods and all of the intentions of sticking to a plan with co-design, but it's not always going to go the way that you want it to, and you need to learn to adapt and pivot pretty quickly. You also need to seize opportunities when they arise. So we had to do a lot of things like using existing work meeting times to put co-design into. We had to grab people while they're available and make it work. So you have to learn to spot an opportunity and to jump on it when you can. You need to be prepared to be pleasantly surprised as well. So I got quite frustrated that I couldn't get this beautiful workshop one up and running that I had in mind, and it ended up being split into 3 much shorter workshops, which meant that one of them only had 3 people in it. And that was actually a really wonderful experience because we had the time and the space to really delve into things deeper, which wouldn't have happened if we had that bigger group. And also be comfortable with making it up as you go along. It's good to follow a plan, but you also need to get comfortable with just making it up and being okay with that. Okay, so at its core, co-design isn't just about systems or processes, it's about people. So they're not just as stakeholders or names on a list, but as keepers of the real stories that matter. And this is another thing that can happen to researchers if we're not careful, is we start to see people either as data points or as participants, and you can often forget that people are people and that they have these stories that need to be told and that are really, really helpful for the work that you're doing. So the people who work, care, and are cared for in these services carry these experiences that no amount of data can capture. Real lasting change doesn't start with a new model. It starts with those relationships, with listening and with building trust. So like I said at the start of the presentation, that first point of engagement being our steering committee and building that mission statement together, that kind of engagement, those kind of relationships is where change really starts to happen. And it also helps with building trust. So through this process of co-design, all of us had a chance to see a journey through someone else's eyes, and that was really important. So we're able to understand different perspectives and to shape something better together. So that, more than anything, is what makes co-design powerful. As a researcher and as a carer, the people in this process have been the ultimate reward to me. Hearing their stories and spending time with people has just been amazing. It's been really, really wonderful. So are we making it up as we go along? Yes and no. So you need to adapt constantly during this process. So in that sense, yes, you are making it up as you go along. But at the same time, there's an arsenal of co-design methods out there that are based on really well-established techniques. So you're not really making it up as you go along. But ultimately, we have arrived at exactly where we need to be for this project. I've added this very busy slide in. It's from another presentation. I'm being a bit cheeky and cutting and pasting. There's a few things in here that I would like to point out. So this is all things that I learnt during my process of working out how to do co-design. Did we use a lot of these things? Possibly not. But some of them have been really helpful to keep in the back of mind. And I think the most important one is that when you're working with consumers, you need to remember that their personal goal might not be to have a better service. Their personal goal might be to never need that service at all. And that can really impact engagement and the input that you end up ultimately receiving. The other big thing I want to say, and I'm sure everybody's doing it anyway, you need to budget for consumer payments because their time is really, really valuable. The information that consumers have for you is worth its weight in gold. So they should be paid for their time accordingly. But other than that, that is me done. Now that I've put you all to sleep, I would like to acknowledge the support of the Victorian state government in this work, who funded through the VCA, funded this project, and will continue to keep me in a job for the next 2 years until we get this research done. But other than that, I will hand back to Craig and any questions that you might have. I'll stop sharing.
Fantastic. Thank you very much, Stacey. Very practical and entertaining talk. Thanks very much. I don't think there were people asleep at the end. We've got a couple of questions on the Q&A, which we'll go through. But, oh, sorry, they're pouring in. We've now got 4, so we'll go get to those. Thank you very much, everyone, for attending and for the questions today. Please type into the Q&A box if you have others, and we've got plenty of time to go through those. So, it's not meant to be just a didactic lecture. It is meant to be interactive. So happy to try and pick Stacey's brains now on this issue of co-design. So the first one's from Joe Risk. She just asks, is the scoping review available, please?
Good question. So we are in the process of writing a publication of the whole process, the whole co-design from scoping review to the actual co-design itself. It's in draft form at the moment, but hopefully If I can get my act together, we'll get it finalised and submitted shortly. So hopefully there'll be something due, something available soon. Academic world soon. Take that as you will.
Thanks, Stacey. Then we've got a question from Patrick Daly. Thanks, Patrick. Can you provide any more information about how the trigger points and cancer types are explored and refined, please?
So we are we went through the co-design process of trying to identify some trigger points. I found through the scoping review the sort of trigger points that other people were using for early referral, and they included things like ECOG scores. But we sort of fairly closely follow the Care Plus model of early referral, and they have a publication. I can't remember the exact name of it, but I will share that with Heather, and I'll share a link with Heather, and she can perhaps send it out to attendees. But there's definitely some information out there. Where we landed for this project is because we are a relatively small service with resource constraints, where our pilot for this model will be based on upper GI cancers, and we'll be looking at the trigger points for that, which will most likely be, the original idea was just anybody with advanced or incurable cancer diagnosis will go through this process, but we are constantly tweaking that while we work out exactly how many people we can handle. So that's my roundabout way of saying yes and no. There is information out there, and I will try and share what we have.
Yeah, so maybe we can follow up with an email to Patrick after the talk. Stacey will have Patrick's details, I think, because he's registered for this. So another question from Joe Risk. Can you speak a bit about the data emerging about any resistance or barriers to early referral?
So there were barriers on the referrer side. Again, because we have quite a fragmented service up here, and we're across all these borders, one of the biggest barriers for our referrers is the fact that there's a different referral system or method for each. You need to know where your person is going to be referred to, and also how that referral service accepts referrals. Some of them are quite complicated and need all of the details, whereas some of them will quite happily just accept an email saying, "Can you please see my patient?" So that seems to be quite a barrier. Another big barrier to referral, I think, is the discomfort that people have with discussing palliative care. And that again comes back to that idea of the stigma that's attached to palliative care. I guess it's all about marketing and salesmanship, really, when you think about it. So a lot of people aren't comfortable opening the door to the idea of palliative care, because they do see it as, okay, the oncologist is giving up on me, or from the oncologist perspective, so I am failing. And there's a lot of literature on this as well, a lot of really good qualitative literature around both sides of the coin. So the biggest barriers, I think, from what we have looked at, have been the processes themselves, the systems and processes, and the stigma around palliative care. Does that kind of answer the question? Please do tell me if I'm waffling.
No, it's good, Stacey. I think it's a good answer, good question. I think, there's quite a lot of general perception that referral to palliative care is done at the very end of life and not early, despite all that evidence that early referral can have significant improvement in outcomes. So, it's a day-to-day reality, I think, for clinicians and patients to try and discuss and overcome that sort of stigma about the early referral. And so we've had really good, robust discussions with the steering committee, and which includes, you know, people with lived experience of cancer. And we've been debating about what to call the clinic. Should it be called a palliative care clinic, or should it be called Care Plus or Supportive Care Clinic for Cancer? And those discussions that decision's sort of unresolved. So it's an ongoing discussion ahead of establishing the clinic later this year about what to actually call it, in acknowledgement of those barriers, and hopefully reduce the barriers to people accepting referral. So if anyone has any suggestions for names, because this will be something that's discussed and considered in other regions as well, we'd value any feedback on that in the chat. Question from Kylie Bauer, if we want to change tack a little. What support did you provide to the lived experience stakeholders to avoid tokenistic input?
It's a very good question. And you're right, it's very easy to slide into that kind of area of, okay, yes, we do have consumers on our committee. We do have consumers involved in our discussions. So our consumers are really deeply embedded into the project. They're authors on our documents. They're authors co-authors in the publications that we're working on. They're members of our steering committee. We do spend a lot of time not together because we're not in the same locality, but we're in contact quite a bit. Their feedback is and their ideas are really embedded into what we're doing, because ultimately they're the ones that we are trying to provide a service to, that we're trying to support. So it is very easy to overlook what they're saying, especially when it goes against the day-to-day kind of constraints that health services have. So I feel at least there's probably a much better way to do things than what we've been doing. Like I said, I'm new to co-design, but I prefer to stay in contact with our consumers and bounce things back and forward with them. If I have questions about something that they've said, or somewhere that I want to take something, I'll contact the consumers. I'll contact we have a really active consumer on our committee, Kathleen Wilkins, who heads up Every Voice Can, and she has put a lot of effort into learning about research and learning about being a consumer representative, and I will quite often bounce things off her. But yeah, if Kylie, if you've got any other input into how we could do it better, I would really greatly appreciate it, because our process is not finished yet. We've still got work to do.
Yeah, thanks, Stacey. We can also have the opportunity to put formal processes in place if needed. But we've got a question from Virginia Dixon Swift, which is sort of segs along similar lines. So Virginia's been a collaborator in the grant application for another project. Thanks for joining in, Virginia, who's very experienced in co-design. I'm not sure whether she's in Jaja-Warong country in Bendigo today, or down the coast working from home. Her question is, you talked about the project being emotionally demanding for patients and staff. Does that apply to the researchers as well? What did you have in place to lessen the emotional burden on all these groups?
Another good question. Yeah, absolutely. So researchers is me, myself and Craig is also staff as well. So we did find during the co-design process that we both got quite emotional, like as a lived experience researcher, I did. And Craig also, I think, probably doesn't mind me saying, impacted him as well, because, it's even though you're working in these areas on a day-to-day basis, sitting down with other people and actually telling stories is more humanizing, I think, and it does tend to trigger a kind of emotional reaction, and which I think is a good thing, because if you're not reacting emotionally to these subjects, then there's probably, I wouldn't say something wrong with you, but perhaps you might need some help. So to lessen the emotional burden, we did spend time in the co-design process talking about how we might support each other, or if we need to stop what we're doing and take a step back and put in place whatever methods of sort of resolving that emotional reaction, which could include contacting people. We've got a really wonderful service at the Ururudonga Regional Cancer Centre, social worker and a psychologist who both agreed to be on hand if needed. But Craig and I we meet up weekly to discuss things. It's a good opportunity to talk these things through. So you do really need to, and I think even if I didn't have that lived experience with my own family, I think this sort of subject matter gets to everyone. So yeah, massive emotional burden, but also really positive on the other hand. So yeah. I hope that answers your question, Virginia.
Yeah, thanks, Stacey. So, we have a weekly catch up, which is about the logistics of the project, but it's also an opportunity to debrief as researchers, and as a medical oncologist, I've had in place formal support with a clinical psychologist for a number of years to be able to talk about various issues, and I would encourage anyone who works in medicine, in health, to consider having the same steps in place. I think it's surprising that don't have those formal arrangements in place for everybody. So moving along, there's a few more questions we'll try and get through. So maybe some briefer answers if possible. Stacey, the next one's from Ashwin Kanaya. I hope I pronounced that correctly. Thanks for this timely project, Stacey. From a barrier to referral perspective, do you think that having updated advanced care directive discussions might facilitate trigger points for timely referral? Was this discussed in the workshops?
Yeah, absolutely. So advanced care directives are a big part of what we're hoping to do with the process as well. It is a good trigger point, and people just telling you that they want more help is also an excellent trigger point. I can't speak for the clinicians, but my sense is that most people don't have an advanced care directive, and they won't have one right up to even the very end. So it would be good, obviously, if somebody came in with a advanced care plan or an advanced care directive to their oncologist, that would certainly trigger a referral. But certainly in our region, I think those ACPs and ACDs are sort of made with the palliative care physicians, and quite often not beforehand. So it would be a sort of chicken and the egg situation, at least around here.
Thanks, Stacey. Yeah, and just to point out too, we have proportion of patients with advanced care directives before and after implementation of the clinics, actually one of the endpoints. So we're hoping that we'll see a lift in the number of people who have advanced care directives put in place once they're referred to the early palliative care clinic. Joe Hooper has a question. I guess it's about maybe the re-aim methodology that we're using as part of the co-design process, given the 5 identified stages of referral, are you looking in any detail the identification, screening and discussion elements and identifying areas for improvements in your model development?
We sort of we went through that a little bit in workshop 2, looking at pain points in the model that we had, the draft model that we had developed, and looking at opportunities for improving those pain points. We will be using the, as Craig just mentioned, the re-aim model. So once the clinic's up and running, we'll be keeping a very close eye on it, and in conjunction with our steering committee, so that we can make changes and adapt again and make it up as we go along a little bit more, to ensure that we're still doing things, or that we're doing the best that we can to ensure success for this model. So we will definitely be constantly looking for areas of improvement and change. Hopefully that's answered your question.
Yeah, fantastic. Now, Stacey, I had a question for you. You referred during discussion to practical design. We had the 3-month process to do it because of basically Christmas holidays in January. We wanted to compress the process. So how did that differ to what would be considered a classical co-design? Would that go on for much longer? Do you want to explain that to the audience?
So a lot of the research that I read, and a lot of the people that I know that have worked in co-design, some of these projects can take, just to design something through a co-design model can take 18 months or longer. Sometimes funding is given for a 3-year project that is purely just designing a thing before you even get to implementing it. So it can be quite a long and drawn out process to start from scratch, to really build from the ground up. So obviously we just didn't have the time with this project. So we've done what we think balances the practicality of it with having actual meaningful engagement. Time will tell. We will take the opportunity at the end of the project to write another publication about whether or not that worked. But we feel that the sense that we have at the moment is that this is kind of arrived at where we need to arrive.
And it was a co-design process in a sense, in that we did actively engage the steering committee, the participants, to ensure that slightly lessened, slightly shorter duration was still acceptable to them, was not seen as tokenistic, that is still an effective process. But it shows that you can still, I think it showed me that you can incorporate a co-design element into most projects. It can be, a short and sharp but effective process to ensure that you are actually getting the valid and effective input of participants. We're running short of time, so I'm going to finish with, there's a lovely comment from Stephen Cavill. Thank you for your important research. This is not a question, just some feedback on the research project itself. My experience indicates there's plenty of work to do. I'm a patient, not a researcher. I was diagnosed with prostate cancer in 2012. A few years, I asked for a referral to palliative care at my regional health service and was told to come back when I was sicker. Maybe that's not what they said exactly, but that's what I heard. So I hope the outcome of your research improves that situation. Thank you very much, Steve, for that feedback. I think in some places, I think because of resource constraints, there is a policy in place for people need to be determined to be within 6 months of their end of life to be kept on palliative care. And one of the things as part of our process is it's a step care. So you have 3 visits and then you are back with community palliative care service and come back in if there's a significant change in health status. And so it can be re-referred back into the palliative care clinic. I'm going to now share my screen. While Stacey was talking, I Googled on the At Research website. Here we go. Can you see that, Stacey? I think that's working. So I typed into the search function on the At Research website, co-design, and you'll see it comes up with a whole list of various resources that people can refer to. There's a really important guide to co-design with Aboriginal and Torres Strait Islander people. That was a piece of work undertaken by Cancer Australia. There's experience-based co-design toolkit, which is a 150-page PDF file that gives you a guide to co-design. So there's lots of resources on the At Research website. I'm going to switch to, I'm just going to thank everybody very much for their participation today. Thanks to Stacey. And just wanted to put this up. I'd really value if people could use their phones now to take a picture of the QR code. We'd really appreciate if you could just take a minute to give some feedback on today's presentation. Also wanted to point out, if you come across resources about co-design or other health services research issues, please email them into us. We're continually updating the website. This is, regional Victoria, it's regional clinicians website. And so if you come across things you think are valuable to share, please get in touch with us and we'll put them up onto the website. So I think if there's no other questions, we will close today's session. Again, just thanks very much, Stacey, and thanks to everybody for participating, and thanks to that research team behind the scenes who have put together today's webinars. I can see Steve's got a hand up. I'm going to stop sharing and see if I can let you talk, Steve. I think I can do that. Or maybe someone backstage can help me.
I'm not sure that we can actually do that, Craig.
Oh, okay. No worries.
Because we're in a webinar and our audience are participants, but only audience. So we'll catch up with Steve when we've got your email.
Oh, Steve's just posted in Q&A. It was an accident. No worries, Steve. I was just getting a chance to talk if we could. Thanks very much for your input, Steve. It's really valuable to get the feedback. And ultimately, that's the whole point, isn't it? We're trying to improve outcomes. That's why we are doing the project, to see if we can prove that early referral is effective and we have that co-design element as well. So thanks very much.
Yeah, and thank you, Craig and Stacey. Great webinar, and we look forward to meeting everyone who's attended today next month. Thank you very much.
Thank you.